So today we'll be talking more so about how constipation and the bowel it goes with in the pediatric setting, and what we can do for our kiddos that are suffering from constipation and how we can help improve their regularity. And then at the end, I will be talking a little bit about what pelvic physical therapy looks like for children. So we just finished up a wonderful talk by Linda on bowel function. So I don't need to go through a whole bunch of it. I'm sure you guys understand how food gets from the mouth down to the rectum and the anus. But one part of it that I really want to point out is how the actual urge of a bowel movement comes on. Is that as stool is collecting in the rectum starts to stretch, and those, oh, you lost my picture. My own picture, huh? That's probably, all right. Sorry about that. I just got a message that you guys lost my picture, but hopefully you can see my screen. And that's one of the most important things. Okay. All right, so sorry about that. So when stool is collecting in the rectum, it starts to stretch, and there's delicate nerve endings in this area that start to detect the presence of solid, liquid, or gas contents, which is why you tend to know what you have waiting for you. And your brain can then make the decision on whether or not you want to go to the bathroom right away, whether you need to defer it, whether you just need to pass gas, which wouldn't necessarily require going to the bathroom. And then you decide if defecation is actually convenient or not. And this is a big one for our kiddos because kids love to play. The last thing they want to have to do is to stop and have to go to use the restroom. So we'll be talking a little bit more about that, but that is a big decision point for our kiddos. So we really want to be teaching them to listen to their body and to not ignore these signals. So once you do sit down on the toilet, then your pelvic floor, just like with bladder function, your pelvic floor is going to relax. Pressure in the rectum is going to increase to push stool out. And then as soon as the stool exits and defecation is complete, then the pelvic floor is going to involuntarily contract again to help make sure that nothing is escaping. So you see on the right here, just another version of the Bristol stool scale. So this is showing us the different types of stool that an individual might have. So just like with adults, we're trying to aim for the type 3 or type 4, more sausage-like looking stool, and that's the same for kids. And we'll be talking later about how the type 1 and type 2 above can be signs of constipation. In terms of the frequency, obviously when children are infants, they are having a bowel movement a lot more often than an older child or an adult would. And so it just tends to decrease with age. By age 4, it tends to reach more of an adult frequency. So we're looking at about 4 to 9 times per week, just like with adults, you don't have to have a bowel movement every single day, but I would say with children, it's really good to be monitoring this with your kids, especially as they get older and they don't need your assistance in the bathroom anymore. It's still a good idea to have an understanding about how often your children go, because I find that a lot of parents don't always know. You should be able to defer a bowel movement by 15 minutes, but again, we really want to watch this with our kiddos because as soon as you defer a bowel movement, if you defer it too long, you're going to tend to lose the sensation, and then you're going to forget that you needed to go at all, and that's when something like constipation can rear its ugly head. So this is an infographic here that I found that I really like, but I will admit it is from the United Kingdom. It is not from the US, but I think that a lot of the stats are very similar to what you would expect in the United States. But just to point out a few important things is up here on the top left, 95% of children or childhood constipation is idiopathic, meaning that there is no rhyme or reason that or physiological or anatomical problem that is causing the constipation. So a lot of times we don't know why it's occurring. On the bottom left here, up to 30% of children do experience constipation at some point. And I think that that stat is pretty accurate. I want to say that it was about 29% more recently in the US, so not too far off. And toddlers definitely are very prone to constipation, and you're not going to necessarily know about it. And it really can happen across the age span, as we've been talking about. So constipation, on the right here is a picture of an x-ray, and this is what doctors will do if constipation is suspected. It's something called a KUB x-ray, and if you can see my pointer here, oops, clicked by accident, you can actually see this darker portion, this rainbow shape right here. That is actually constipation. That is stool that has backed up in this child's colon. And so this can be a great visual on whether or not a child is backed up. And so with constipation, it tends to get worse and not better. So if you suspect that your child is constipated, even if you suspect yourself that you're constipated, it's really not the kind of thing you just want to watch and wait to get better. You want to be proactive about trying to address it. And so with constipation, one of the reasons that it tends to get worse is because as the stool backs up, the large intestine's job is to draw out moisture. And so the longer stool sits in the large intestine, the drier it's going to get. And then the more that tends to back up, then you're going to get the colon and the rectum actually stretching out more because it's like a really bad traffic jam. Everything just keeps coming from behind, but there's nowhere for everybody to go. So everybody just starts gathering around, and that can lead to stretching of the colon and rectum, which also will lead to weakness of the muscles and the smooth muscles in this organ, as well as poor sensation. We talked about how that stress receptors, nerve endings in the rectum are telling us if we need to go. Well, if there's always something present, our body's going to tend to fade it out after a while. Similar to when we get dressed in the morning and we put our clothes on, we often can feel that we just put our clothes on, and we might still feel that our shirt is on us for the next few seconds. But as soon as your mind is off to something else, you forget. You don't think all day long about how my clothes are on. You don't feel that because your nervous system is very smart, and it helps to filter those kinds of things out. Well, just imagine in this area, if there's a constant stretch, and because there's a constant backlogging of stool, our body's going to tend to fade out that sensation. And so even though it's present, you might not always feel it. And then when it's time for a bowel movement, when a child or a person tries to have a bowel movement, they can be very painful. It can develop in fissures, which are abrasions on the inside of the anal canal. With straining, you can develop hemorrhoids. You're going to get abdominal pain, bloating, gas, and then we'll talk about how fecal incontinence and something called encopresis occurs in children. So not to drill it in again, because I know Linda did a great job at talking about a lot of the causes, but just talking about causes of constipation in the pediatric population. Diet and hydration is a huge one still. We really want to make sure that the kids are getting a good amount of water and they're getting a well-balanced diet. Stool withholding. So stool withholding is when somebody has is not going for a bowel movement, even though they might have a sensation for it. And that can occur especially in kids with pain. Maybe they remember a very painful bowel movement, and so they're afraid of experiencing that pain again. So they hold their stool thinking that it's going to help prevent that pain from happening again. They might be ignoring the sensation. Like I mentioned, kids that they love to play, they might not want to have to stop what they're doing, so they ignore it. The sensation goes away, and then they don't think about it till who knows how long. There can also be emotional reasons too. Think about even our older children. Maybe they don't want to have a bowel movement at school. Maybe they're embarrassed to. Or not that this is on an emotional level, but maybe they're more fearful about a toilet being unclean. They don't want to sit down on it and have a bowel movement. So they might be withholding stool for those reasons. Poor physical activity, again, just like Linda talked about, that's a big one. So think about the kids that just sit and play video games all day. They are not moving their body, and gravity is not helping stool to get dropped down and to move along in the large intestine. Changes in routine, like travel, is a really big one. But I mean, think about when moving, or parents bring home a new baby, or they start a new school, or they start school to begin with. A lot of these routines can really affect a child's bowel movements. Poor muscle coordination, this is more meaning with the pelvic floor. So there are instances when the pelvic floor muscles do not relax, and that makes bowel movements very difficult to pass. And so that can also cause constipation. Underlying medical conditions, a lot of kids with low muscle tone, for example, kids with Down syndrome, it is just a genetic factor in their condition that they have low muscle tone, and that is going to be included in the smooth muscle too. So their large intestine, which has the muscles that's going to help to push stool material, waste material through, they're not going to be quite as strong and going to be contracting in the same way. So their gut tends to be a little slower. Any kind of illness, there are nerve damage instances that can create constipation, and then medications that they might be on can be a big one. And then at the end, the unknown is that there's lots of kids we just have no idea why they're getting constipated, and that is a large portion of it. The signs of constipation, the stool withholding, crying or appearing in pain with defecation, loss of stool in their underwear. If they're not going at least 4 times a week, or even if they are going several times a day. If they're going more than 3 times a day, it could be that they are just so backed up that things are just are needing to come out more frequently. That there's just that long traffic jam that things need to start moving through, and so their frequency of defecation can go up. They might have excessive gas or even foul smelling gas or stool. Obviously, most gas and stool is not a pleasant smell anyway, but you know when something just doesn't smell right. Hard stool or loose stool, and we'll talk about that in a minute. If they're complaining that their tummy hurts or the bottom hurts, if you notice that their tummy is distended, if they've lost their appetite, have poor energy, they're just irritable, because when we don't feel good, we tend not to be happy, and they can maybe throw a few more tantrums than normally, and that can be a big problem. Urinary problems. So I talked a lot last week about incontinence in children, or urinary incontinence. And so constipation, really big link with that. And with frequent urinary tract infections in kids, it's often because they are constipated. So fecal soiling or endopresis is when a child is uncontrollably losing some stool material into their underwear when it's not wanted. And so if you look at these 3 lovely colons here, on the left side, this is more normal. And so stool's collecting, you can see that it's pretty narrow, and there's just a small amount here. But then if you look at the middle one and the right one, a lot more stool is collecting. So what happens is you see that a lot of this stool looks almost like that type 1 rabbit pellet looking stool, and what happens is it stretches, like I mentioned earlier, it tends to stretch out the rectum and the colon. So this is what you would see on that x-ray. And now that these small pellets are all backed up here, the only thing that's really going to be coming through is more liquid stool. So just think about if you had a jar full of pebbles and you poured water on top, how quickly the water would be able to flow around those pebbles. But then the more solid masses just build up on top. And so in this case, a child will uncontrollably lose this liquid because one, it's stretched out, and one, they don't have sensation that it's there anymore because it's always there. So their body has phased it out. And so a child will have a few drops of what appears to be a brown liquid. It can also be just a smearing of some pasty-like substance, or it could even just be a small little pebble that has worked its way out. The children are often unaware of this accident, and that's really important to understand. And I put a note here, it's really important to not punish and not embarrass the child because it happened, because most of the time they do not know it's happened, and it is not their fault that it has happened. So it is not a behavioral outburst. They're not trying to do it to make anybody angry, and it's just an unfortunate accident that tends to happen. If it does happen occasionally or frequently with your child, it would be important to get them to see a doctor to look into constipation. So, and I didn't mention this last week with the bladder as well, is that urinary accidents often also don't happen because the child is doing it on purpose. It's important to work with the child to try to figure out what's going on and how to stop it versus get angry at the child or punish the child because it's happening. A lot of times there's something bigger going on that the child cannot help. So some simple strategies. Now these are going to be if you do suspect constipation with your child, but I think a lot of these are also just really important habits and routines to develop with your child from potty training on. I think the earlier you start these things, the easier it is to ingrain it in them. So the first one being drink plenty of water. Make sure they're getting that 6 to 8 glasses of water a day. And as we talked last week, you could use half of a person's body weight in pounds, and that would be how many ounces of clear fluid they should have. Make sure they have a well-balanced diet. So fiber is a big one, but as Linda also mentioned, too much fiber can make you blocked up and constipated as well. A good rule of thumb is to take a child's age and add 5 to that, and that's roughly how many grams of fiber you should be aiming in your child's diet a day. You really want to limit this really starchy food, the real processed food, because that tends to be more constipating. Dairy can be constipating, and it's really important that they chew their food well. I know I watch my own kids and I see a large mass of food go in their mouth. Maybe they chew it 2 or 3 times and down the throat it goes. And so it's really important to be encouraging with your children that they chew their food well, because that is going to help the digestive system in the long run. Exercise routinely, also a big important thing. They've got to be moving around, and that is going to help to move things through their digestive system. And then sitting on the toilet at the same time. I think that children from potty training on, if they get used to having a routine bowel movement or having some time where they just sit and relax on the toilet, can be a really good habit to get into. And it's best to try to do it about the same time every day. After a meal tends to be best, and morning tends to be best. That's when our digestive system tends to be the most active, and when most people tend to find that they have the best bowel movement. Posture is a big one, which I'm going to talk about toilet posture in a second. There's also a bowel massage that you can do, which I will be showing hopefully a small video of at next week's webinar. If you look on the right here, the toileting posture, This is an ideal toileting posture. Linda talked about it. Get a little stool, try to get the knees higher than the hips, a slight bend forward in the trunk, but it's important to keep the back straight and don't just fall over and curve your back. Prop yourself up on with elbows. So with children, especially once they've graduated from a training toilet to a training potty to the actual toilet, it's really important to get their feet supported. Don't let their feet just dangle. They need to be able to relax, and so having a proper, even smaller toilet seat for them and proper foot support is really important for them. And then encourage ways to relax on the toilet. The toilet is not about trying to rush through it. Just like with urinating, we need to encourage children to take their time when sitting on the toilet to have a bowel movement and make sure that they get everything and that they're really relaxing. It's important to relax the stomach, to relax the bottom. And ways that you can do this to help children is things like deep breathing, gentle songs with them. Blowing bubbles is a great way to get them to relax their pelvic floor, and even blowing a pinwheel. So with small children that are learning how to sit on the potty, or if your child is experiencing constipation and you want to encourage more relaxation on the toilet, have some bubbles and a pinwheel or something that you can do for your child while they're in the toilet to keep them engaged and to help them understand ways to relax. If your child needs extra help, if the general recommendations that we just went over do not help, they should go in to see their pediatrician. And like I mentioned earlier, they might do the x-ray called a KUB to rule in constipation. They're likely going to educate you on diet and supplements for the child to help with regularity. They might be recommending laxatives or medications in general, which might include laxatives, stool softeners. A clean out is when you use a high dose of laxatives to over a few days to encourage full clean out. It's similar to what you do after, or before a colonoscopy, is that you just want everything cleaned out, and then they often will keep the child on what's called a maintenance dose of a laxative, so that they are clearing out routinely. They might also recommend suppositories or enemas. And if a pediatrician feels it necessary, they might send the child to a pediatric gastroenterologist to help with more types of diagnostics. This might include something called anorectal manometry, which helps to understand the function of the anus and the sphincter muscles and how well a child is able to feel sensation. So they actually insert a balloon and they fill it up, and they can see at what degree of filling a child can identify. And this is also something they do with adults, when the child is able to identify that there is something there and they feel like they need to have a bowel movement. That can be really valuable information so that we know what kind of sensation the child has. And then there's also biofeedback, which is something we often do in physical therapy, but some GI doctors' offices will also do it in-house. If therapy is indicated for these children, they might be sent to a specific pelvic PT. There's also occupational therapists who do specialize in pelvic health too. So they might be sent to an OT. Traditional pediatric PT and OT can be very valuable. A lot of that is because we do a lot of core strengthening and sensory integration. So children who just have difficulty regulating their sensory system, there's lots of interventions that can be done in traditional PT and OT to help with this. Speech therapy can be helpful if the child's having difficulty communicating about a bowel movement. And then in the case of autistic children, ABA might be helpful to help make goals about the act of getting to the bathroom and identifying when they need to go. Schools, it's really important to be talking to your children's teachers and the school nurse about what's going on with your child if you are suspecting constipation or really even anything that's going on bowel or bladder wise, so that the school and the teacher understands that this child needs to be able to go to the bathroom whenever they need to go, without any kind of repercussion. It's really important. And there are ways, it's important to be talking to therapists and doctors about ways to work this with your teachers. If it's necessary and your child has an IEP, you might want to make sure that goals are added to assist with toileting at school, or even a simple 504 plan. So if your child does end up in pelvic physical therapy, what are we going to do? A lot of people think, wow, well, I know what you do with an adult, but what on earth are you going to do with a child who doesn't understand everything? So if a child walks into the office, I will do an extensive parent and patient interview depending on the age of the child, but I do want to hear the child's view about what's going on. So I know how to cater our interventions to that child and to the family. And it will likely involve an external exam of the perineum. So I'm looking at, in the case of constipation, I'm looking at the function of the anal opening. I'm looking to see what does it look like at rest. There might be some palpation involved. If I do feel that it's necessary to feel on the outside of a patient's pelvis, I will ask not only the parent or caregiver, I'm going to ask the patient too. I don't care if they're 3 or 4 years old. If they say, no, I don't want you to touch my bottom, I am not touching their bottom, no matter what the parent says. So usually if they say no the first visit, after a few visits with me, we develop a rapport. They might feel a little more comfortable as long as their parents are also comfortable with that. But it's really important to get consent from both parties. Internal exams are extremely rare. It is not something to be expected, but there's very few cases where that might be necessary, and that's going to take a lot of thought on the therapist and the parent and the individual. To decide on that. There's going to be an inspection of the abdomen, so looking to see, does the tummy look distended? Does it feel like they're constipated? Can I feel stool backing up in the area of the large intestine? I might even use a stethoscope to listen for bowel sounds. Other gross motor assessments, I like to see how a kid moves. Are they strong? Are they meeting their milestones? I'm going to look for diastasis recti. Children have it too, just as men have it, as well as we've learned that women have it. It's with children who are constipated, they will often have a diastasis, which is that little bulge that forms at the midline of their abdomen. So I want to look for that with children. I want to see what kind of flexibility they have and what kind of strength and coordination they have. It's not just about their pelvic floor. It can be about how their hip strength is and what kind of postures they have. And then I will at the examination, I will also give a bladder diary, or excuse me, it should be a bladder or a bowel diary to the family, so we can start to see what the patterns are with the patient. In terms of treatment, initially a pelvic physical therapy session with a kid is going to be a lot of family education on their fluid intake, their diet, ways to prevent constipation, similar to what I just talked about on the previous slide. Toileting posture, the bowel massage technique that we'll learn next week. If bladder is the concern, how best ways to empty the bladder. If bladder retraining, timed voiding, or bedwetting training needs to occur. We may decide to do pelvic floor coordination exercises, and this is where I said before, I don't really love suggesting that kids do Kegling just for the sake of trying to strengthen them. I'd rather it be done under the supervision of a medical professional, because children are a lot harder to read if they're why they might need it and what is going on. So I think it's important that you get an opinion before asking your child to do Kegels. And it's really important for kids to understand how to contract and how to relax. So we might utilize biofeedback, or it's fun for kids. They often like that it's almost like playing a video game, where sensors are placed on the external pelvic floor, and it's hooked up to a computer, and you can either watch a graph, or we have animations of a rose opening and closing. And what the computer is reading is when the pelvic floor is contracting and relaxing, and the outcome is what's occurring on the screen. So it can be fun for kids to learn how to contract these muscles using the biofeedback program. We do a lot of breathing exercises and a lot of core function exercises. And these are things that we will also be going over next week. I will be hopefully showing some videos on some of my favorite exercises for breathing, the bowel massage, and my favorite core exercises for kiddos that will also be really helpful for children with pelvic floor dysfunction. So I hope to see you all next week.